Hello there, I'm Nurse Mo, and this is the Straight A Nursing Podcast where I teach concepts and share tips on how to thrive in nursing school and beyond that at the bedside. Today, we are diving into a pharmacology topic that has been on my mind a lot lately, probably because I work in the recovery room where we give a lot of pain medication. So I'm going to be giving you some highlights about 8 commonly used pain medications in the clinical setting. Before we hop into that, though, let's take a quick minute for our listener shout out. This one goes out to Cass, who says, "It's like having a cool study buddy in the car with you. As a first-year nursing student, I feel guilty doing anything else but studying, and straight A nursing is a great form of infotainment." Well, thank you, Cass. I don't think I've ever had the term infotainment used to describe the podcast, so I think that means you find it entertaining as well as informative, and that makes me really happy. So I want to wish you all the very best in your career as a nurse, and thanks again for taking the time to share that the podcast is helping you. Alrighty, so talking today about pain medications. A very, very common intervention that nurses do is, of course, manage pain and administer pain medications. So I'm going to talk you through 8 commonly used pain medications, kind of the key highlight things to know. Before we get there, though, I do want to talk to you very briefly about something called the analgesic ladder. And this ladder is basically a framework that was proposed by the World Health Organization in 1986. And it was created as a way to improve the management of cancer-related pain. Since then, it has been updated and it is utilized to guide pain management for a broad range of both acute and chronic conditions. So this updated analgesic ladder consists of 4 steps. So looking at step 1, basically for mild pain, the ladder guides us to utilize non-opioid analgesics such as acetaminophen or NSAIDs. And then we may add adjuvants as needed. So you might be asking yourself, what is an adjuvant? So an adjuvant is a non-opioid medication that is used to enhance the effects of pain medications or provide analgesia for a specific type of pain, such as neuropathic pain. And some common adjuvants include antidepressants and anticonvulsants. And we'll talk about a commonly used anticonvulsant in just a moment. So again, step 1 is mild pain. We're going to use non-opioid modalities for that, and then we may add an adjuvant as needed. Step 2 is for moderate pain, and this is where we start introducing opioids, and we're using weaker or less potent opioids. Really important to use the least amount of opioid to produce the desired effects. That's why we have the stepwise framework as proposed by the World Health Organization. So with moderate pain, we're using weak opioids. This could include tramadol, hydrocodone, or codeine. And then, of course, we may add a non-opioid pain medication here, like add on some Tylenol or an adjuvant as needed. And then step 3 is for severe pain. And now we're using those stronger opioids like morphine, oxycodone, hydromorphone, and fentanyl, and even methadone. And we can also, of course, add non-opioids to this to help improve pain management and adjuvants as needed. And then step 4, if the pain is persisting, we go further. And this includes invasive and minimally invasive non-pharmacologic interventions, including surgery. So for example, let's say you have a patient with severe back pain and they're taking all the medications. Maybe they're on a fentanyl patch because their back pain is so severe and it's not necessarily helping. Hey, how about, can we look at this patient as a surgical candidate to improve their pain? And yes, this happens all the time. Patients will be in a lot of pain for something chronic, get surgery, and the pain is improved. All right, so there are some critics of this ladder. And the critics state that it doesn't really take into account individual differences in medication response or pain tolerance In addition, the reliance on opioid medications for moderate pain is considered by some to be short sighted and that it doesn't take into account the risks associated with opioid medications. However, the latter does remain very, very useful for understanding that stepwise approach to pain management, though experts suggest more research is needed in this area. But I wanted you to be aware of it, and it gives you a general idea of how we approach treating pain, whether it is mild, moderate, severe, or intractable or not responsive to treatment. Alrighty, so we're going to be first talking about non-opioid medications. Now, I know when we think of pain management, we often just our minds go straight to opioid medications, but there are actually quite a few non-opioid options available, and they can be very effective, and they obviously have a lot less risk for the patient. The risks with opioids are things like respiratory depression, overdose, oversedation, and long term dependence. So, some commonly used non opioid analgesic medications are acetaminophen, ketorolac, and gabapentin. So let's first talk about acetaminophen. Very, very commonly used in the US. We often utilize the brand name Tylenol, the PO version, Tylenol. This is a non opioid analgesic, and basically, we're using this for mild to moderate pain, and it can also treat fever. Now, acetaminophen is great on its own for that mild to moderate pain, but it is also often used along with an opioid medication to treat severe pain. And as a nurse working in the recovery room, one of my favorite combos is a little bit of opioid medications such as oxycodone or Dilaudid, and then getting some Tylenol on board as well. It's almost a magical combination. So acetaminophen is available in PO form. Again, Tylenol, very common in the US. IV, and the brand name utilized where I work is Ofermev. And then there are also rectal formulations as well. Now, the oral and rectal acetaminophen formulations are going to reach that peak concentration in about 30 to 60 minutes, while that IV form begins to take effect almost immediately. And I saw some studies as I was researching for this episode that said the efficacy of IV Tylenol or IV acetaminophen versus PO is about the same. I swear, from my experience, from using it a lot in the recovery room, the IV formulation works so well. But this could just simply be because it does take effect so quickly. It is more expensive, so that is why it is not routinely used. If the patient can take PO, then the MD is likely to prescribe PO acetaminophen. So here are a few key things to know about acetaminophen. One is that it is used very cautiously in individuals with mild liver impairment and not used at all in someone with active liver disease or liver failure. And that is because acetaminophen can result in liver damage, and an overdose of acetaminophen especially can cause liver damage, can cause liver failure. So we don't want to kick the liver while it's already down, right? So if the patient has some hepatic impairment, most likely going to get a very reduced dose of acetaminophen or maybe not at all. Now, that max daily dose is something else to take into consideration, and this can be a little bit confusing. So when you look at, let's say you look into your drug guide or you're looking at the pharmacy notations on the MAR, it will probably say something like the max daily dose is 4 grams. However, if I go to my linen closet and pull out my bottle of acetaminophen, it's going to say the max daily dose is 3 grams. So, in general, maybe in the clinical setting, because patients are more carefully monitored, we can go up to 4 grams. And this will, of course, depend on your facility and the prescribing physician. But also, 3 grams in 24-hour period is also very common. So, max daily dose, 3 to 4 grams, and no single dose should exceed 1 gram or 1,000 milligrams. And then again, if the patient does have some liver impairment, that max daily dose is going to be less. All right, so that is acetaminophen, very, very commonly used in the clinical setting. Next up, we have ketorolac, which is often referred to by the brand name Toradol. And this is a non steroidal anti inflammatory drug or an NSAID. And it is very commonly used to treat moderate to severe pain after a surgical procedure. And it works fabulous. I love this medication. It is available in oral, IV, IM, or nasal spray formulations, though in the clinical setting, I most likely am using it as an IV medication. Now, Toradol or ketorolac is really, really effective, especially when utilized along with opioids. And the reason we do this is not only because it improves pain management for patients, but if we can improve pain management for patients, guess what happens to their opioid use? It decreases. So if we can decrease post-op opioid use, by all means, that is a good thing. So a typical adult dose of ketorolac is 30 milligrams every 6 hours and should not exceed about 120 milligrams in a 24-hour period. That is what the drug guide I looked at for reference stated. So here are some important things to know about ketorolac. First off, it is not to be used in those who are at high risk for bleeding or with current active bleeding. So let's say you've got a patient. I hope this would never happen, but let's say you've got a patient with a GI bleed and they go in for some kind of procedure and then afterwards they're prescribed ketorolac. I hope like heck you would call the physician and question that order because we're not going to give ketorolac to someone who is bleeding. Now, it is also used cautiously or even not at all in individuals who have renal impairment, as it can negatively impact the kidneys. And this can lead to increased fluid retention and all the problems that go along with that. It can also specifically cause GI bleeding, especially if the use of it is given over like 5 days. Like if we are up to 5 days or more of ketorolac, super, super high risk for GI bleeding. So it's going to be contraindicated in individuals who have active peptic ulcer disease because those ulcers, they're not benign. Peptic ulcers can bleed and they can bleed in a devastating way. So we're not going to be giving it to patients with active peptic ulcer disease or again, any active GI bleeding. Also, just as a reminder, its use really is limited to no more than 5 days. And then in your patient who has had a colorectal surgery, interesting study I found said that it has been shown to increase the risk for anastomotic leaks in colorectal surgery. So it's not typically going to be utilized after that type of surgery. Or a lot of times you won't see it used after specific types of GI surgeries. I had a patient not too long ago in the recovery room who had an abdominal surgery, and the surgeon accidentally nicked the liver a little bit during this surgery and decided not to give ketorolac after the procedure, even though initially they would have for this type of procedure that the patient had, because that little bit of a nick on the liver, high risk for bleeding there, they didn't want to do anything else that would cause the potential for more bleeding. So that is ketorolac, also known as Toradol. And then the other common non-opioid analgesic that I mentioned is gabapentin. So gabapentin is a really interesting medication that is commonly used as an adjuvant and is especially effective in treating neuropathic pain. Now, it is a CNS depressant. So just because it's not an opioid doesn't mean that it can't cause CNS depression. So you have to take that into account when you're administering it to your patients. So it has also got an interesting classification. It is not only classified as an analgesic for specific types of pain, but also as an anticonvulsant and a mood stabilizer. So if you've got a patient and you see that they are taking gabapentin and you think, oh, I wonder if they have a seizure history, and they don't, there's a very good chance that they're taking it for neuropathic pain. So some important things to know about gabapentin are that it can cause drowsiness And confusion, again, it is a CNS depressant. It's going to depress the central nervous system. It can also cause dizziness and ataxia. Now, if your patient is taking another medication that causes CNS depression, such as opioids or even an antihistamine, then they will be at higher risk for CNS depression when taking gabapentin. And then it's also important to know that there are different formulations of gabapentin, and they are utilized for different things. The brand names utilized to treat neuropathic pain are Gralise, Gralise, hope I said that right, and Neurontin. Okay, so that was our brief overview of three commonly used non-opioid analgesic medications. Next, we'll talk about opioid medications, and we're going to be looking at the combo hydrocodone acetaminophen, oxycodone, morphine, hydromorphone, and fentanyl. So, first, let's look at just some general things to know about opioids. And a really important concept to understand when you're administering opioids is something called equianalgesic dosing. So, there is an equianalgesic dosing chart, and I've included a mock up of what that looks like on the blog post that is basically the transcription of this episode. So there will be a link to that in the episode notes if you want to go to that blog post and see what that equianalgesic dosing chart looks like. And what this chart does is it shows how the potency of various opioids compare one to the other. And we utilize the opioid morphine as like the baseline opioid against which the others are measured. For example, the dosing chart shows that 4 milligrams morphine is equivalent to 4D micrograms fentanyl. So even if you knew nothing else about fentanyl, by looking at it on this equianalgesic dosing chart, you can easily see that this medication is much, much more potent than morphine. Now, with opioid medications, you must always, always keep in mind that they put the patient at high risk for oversedation and respiratory depression, especially when other CNS depressants are utilized, such as benzodiazepines, for example. Now, if your patient receives too much opioid medication, what are you going to do about it? You're going to reverse that, and you're going to reverse that with naloxone, okay? And then in addition, opioids are not generally utilized, or they're utilized with some pretty extreme caution in patients taking MAOIs. And this is because there is a high risk for an additive effect of these medications. So this can lead to an additive effect of the opioid, leading to respiratory depression, and an additive effect of the MAOI, leading to serotonin syndrome. So when you know your patient's taking an MAOI and they're being prescribed an opioid, you want to double check this with the physician. So in addition to sedation and respiratory depression, other common adverse effects include nausea, pruritus or itching, hypotension, and constipation. So, nausea, very common with opioids. We can help prevent this when we give a PO opioid by giving the patient a little something to eat. I like to bring my patients some water and some crackers when they're taking something like their oxycodone. Now, if the patient's unable to eat, or maybe they still get nauseous anyway, we can treat that nausea with something like ondansetron, which is a commonly used anti-nausea medication. Now, the itching or pruritus is often addressed with diphenhydramine, but when I say diphenhydramine, I hope your thought went to CNS depression because diphenhydramine can make people a little drowsy, and you know this if you've ever taken it. So this can definitely compound the sedative effects of that opioid medication. And then hypotension can also result. So to prevent the patient from having a dangerously low blood pressure, we're probably not going to give an opioid if they already have hypotension or a low blood pressure. And then opioid-induced constipation can be mitigated with things like increased hydration, making sure the patient's getting enough fluids, increased activity, can we get them up walking, moving around, and a stool softener such as docusate sodium or Colace. All right, so now let's get into our opioid medications, but first let's take a very quick break. I am so excited that fall is finally coming around. I am all about those cozy evenings at home. And you know what makes a night in even better? A yummy bottle of wine. And that's why I'm such a fan of First Leaf. Because I'm a member, I always have a great bottle on hand. First Leaf is a personalized wine club that evaluates my preferences and hand selects wines just for me. And I'm telling you, they hit it out of the park each and every time. Now, as the weather starts to cool off, I go for heavier white wines like Chardonnay and reds like Pinot Noir. And I'm telling you, I received a Chardonnay recently that was definitely a winner and substantial enough to enjoy with my husband's signature fall dish, wood-fired pizzas. Now, aside from knowing my wine tastes almost even better than I do, I also love how easy it is to customize my delivery schedule so I never miss a shipment. And if I ever get a bottle I don't absolutely love, which has never happened, by the way, I know it wouldn't be a problem because First Leaf has a 100% satisfaction guarantee. So get cozy and pop open that perfect bottle of wine from First Leaf. Go to tryfirstleaf.com/nursemo to sign up, and you'll get your first 6 hand-picked bottles for just $44.95. That's tryfirstleaf.com/nursemo. tryfirstleaf.com/nursemo. So the first opioid medication we're going to talk about is a combo medication, hydrocodone and acetaminophen. This is very, very, very commonly used in the clinical setting, and a brand name we use a lot is Norco. So this is a PO medication used for moderate to moderately severe pain and comes in 2 common strengths. And the strength of it is based on the hydrocodone dose, which is 5 milligrams and 10 milligrams. So some important things to know about hydrocodone acetaminophen are that hepatotoxicity or liver toxicity can occur with overdose. And it's not because of the hydrocodone component, it's because of the acetaminophen component. So when you are administering hydrocodone acetaminophen or Norco to your patients, make sure you are calculating all sources of acetaminophen in a 24-hour period so you don't go over that 3 or 4 gram limit. Now, Norco is a very common one. Other brand names include Vicodin and Lortab, so you may see those. And note that the dose is written as 5, 325 or 10, 325. Now, that first number, the 5 or the 10, again, represents the hydrocodone or the opioid dose, and the 325 represents how many milligrams of acetaminophen. All right, next up is oxycodone. Oxycodone, I think, is my new favorite medication to give in the recovery room, and it's because it's so effective and it has a nice long duration of action. So oxycodone, really commonly used, it is going to be stronger than Norco or that combo of hydrocodone and acetaminophen. And it's also stronger than PO morphine, very interestingly. And it can be administered without regard to that acetaminophen dose because oxycodone does not contain any acetaminophen. Now, compared to other immediate release PO opioid medications, oxycodone can have a quicker onset of action and even in some cases start taking effect within 10 minutes of administration. That doesn't mean it peaks in 10 minutes, but it can start to work quickly. Oxycodone is indicated for moderate to severe pain and has a duration of 3 to 6 hours. It's really, really effective. So some important things to know about oxycodone are that It does come in an immediate release and extended release formulations. And you'll see this with quite a few of the PO opioids. So you always have to make sure you know which one your patient is taking so that you avoid accidental overdose. If your patient is taking immediate release oxycodone, then that might be scheduled every 6 hours, for example. But an extended release oxycodone is not going to be given every 6 hours. If you did that, the patient would get an overdose. And then another thing to note is that since oxycodone is excreted by the kidneys, reduced dosing is indicated in patients with renal impairment. Again, oxycodone, super effective. I love it for post-operative pain. 5 or 10 milligrams oxycodone. Patients start feeling better, in not too long amount of time. And then they tend to stay feeling better because it just provides that nice baseline pain control. I absolutely love it. All right, next up is morphine. Now, morphine is available in multiple formulations, though in the clinical setting, what you're most likely going to be giving is IV morphine and maybe some PO morphine. Note that PO doses of morphine are going to be bigger or larger than IV doses, and this is due to the way it is metabolized. For example, 30 milligrams morphine PO is equivalent to 10 milligrams morphine IV. And both formulations can last up to 5 hours. So you'll see morphine a lot on a med-surg floor, for example. Because of the way med-surg floors are staffed, you're not going to be popping in there every hour to give pain medication. You simply don't have time for that. You're not staffed for that. So morphine is great because it can last up to 5 hours. So you're going in there and assessing pain regularly, but probably only having to give another dose of morphine every maybe 4-ish to 5-ish hours. So some important things to know about morphine are that it can have increased effects in your patient who has renal failure. And this is because of the way it is metabolized. And what this does is it puts them at higher risk for respiratory depression. So if your patient has renal impairment or renal failure, then smaller doses and longer intervals between doses is likely going to be the name of the game here. And in some cases, it might just be avoided altogether in these patients. And then morphine is another one of those that is available in multiple formulations, including PO, which is immediate or extended release, IV formulations. It can be given sublingual, rectal, intrathecal, and epidural. Lots and lots of formulations, though, again, what I see most often is IV administration and maybe some PO administration. Though, to be fair, what I mostly see with PO administration is that patient who takes it chronically. Maybe they have chronic pain and they're on morphine extended release at home, and we are continuing that in the hospital. Then that's when I tend to see the PO formulation used. Now, that extended release formulation can have a duration up to 24 hours. So you really, really, again, have to recognize if your patient is taking the extended release formulation to prevent accidental overdose. All right, our next medication is hydromorphone. And then after that, we're going to talk about fentanyl. And I use these two a lot in the recovery room. This is the two most common medications in my recovery room nurse arsenal, right? So hydromorphone, also known as Dilaudid, is another medication that comes in multiple formulations, though IV administration is what is most commonly used in the clinical setting. So some important things to know about hydromorphone is that IV hydromorphone can have a duration of 3 to 6 hours, which is kind of a long time for an IV pain medication. Now, the morphine can last up to 5 hours, but hydromorphone is more potent than morphine. So you do have to take some extra care when administering it and realize that, okay, if I give IV hydromorphone now, 6 hours from now, the patient will just be kind of coming off that effect of the hydromorphone. And what I think about as a recovery room nurse is where is this patient going to be in 6 hours or 5 hours or 4 hours when this medication is still taking effect? Are they going to be up on the med-surg floor where they're not monitored as closely? Are they going to be at home where they're probably not monitored at all? So I have to be very careful, and hopefully everyone is very careful when they're giving IV hydromorphone because its effects can last so long and it is such a potent medication. So the good news is it does provide an analgesic effect for a good long while. The bad news is it can also cause respiratory depression and oversedation for a good long while as well. Note that when compared to other IV pain medications or other IV opioids, it does take hydromorphone a bit longer to kick in. It can take up to 20 minutes for it to really start being effective. And that is another reason to be very careful with it. So, for example, in the recovery room, hydromorphone is typically dosed with a max dose of 1 milligram every 15 minutes. So let's say I give my patient 1 milligram because they're stating 10 out of 10 pain, they're writhing in bed, they're crying, they're inconsolable, they're in a ton of pain. So I administer 1 milligram IV hydromorphone. But let's say it doesn't peak until about 20 minutes, but I can give it again in 15 minutes. So I'm going to reassess their pain. And let's say 15 minutes later, their pain's an 8, which would technically qualify them for another dose of 1 milligram hydromorphone. But you know what? I'm going to wait a few minutes and give it a little bit more time to really peak before I consider giving another big dose of hydromorphone. Again, because it can have such prolonged effects. Now, other routes of administration for hydromorphone include PO, which can be immediate release or extended release. It can also be given rectally, sub-Q, IM, and epidural, but again, most likely you're going to see it IV. And as with other medications, reduced dosing is utilized in patients with hepatic or renal impairment. All right, our last medication to talk about is fentanyl. This is the most potent of all the opioids, and it is available in IV, transdermal, and transmucosal formulations. In the clinical setting, you're most likely to see IV administration, though you will often see fentanyl patches for severe chronic pain, for patients dealing with cancer pain, and that's where that transmucosal comes into play as well. I've never seen transmucosal in the clinical setting. I have seen fentanyl patches a lot, and of course, I give IV fentanyl almost every single time that I work. So, important things to know about fentanyl are that it takes effect fast. And that is one thing that I really like about it. It starts affecting pain very quickly within 3 to 5 minutes. And another thing I really like about IV fentanyl is that it resolves pretty quickly. It has a duration of 30 to 60 minutes. So even if my patient gets, a little over sedated, or, in the recovery room, they're already kind of groggy from anesthesia. We give a little fentanyl and now they're, snoring away or they're just kind of, super drowsy. I know that it's not going to last that long. This makes it just super effective for that type of pain management, that acute, quick pain management where the patient is very closely monitored. Now, fentanyl is, again, extremely potent and can cause profound respiratory depression at tiny little doses. So I don't think they give fentanyl on like the med surg floor, but we do give fentanyl in critical care areas and in the recovery room. So it's so potent, it is dosed in micrograms. Okay, that's very important for you to understand because if you saw a dose of fentanyl written out in milligrams, that would kill your patient very quickly. It would just not happen. Okay. Hopefully, well, I say it would not happen, but then crazy things happen that are absolutely devastating. So I just want you to be very aware that fentanyl is dosed in micrograms. A common IV dose is 25 to 100 micrograms fentanyl, and 100 micrograms fentanyl is a whopping dose. Most commonly, we're giving 25 to 50 post-operatively, though in some cases 100 micrograms is used, but that patient, again, is on continuous monitoring. We're standing right there. We're watching them very closely for respiratory depression and oversedation. And then transdermal fentanyl has a duration of 72 hours. And really important with transdermal fentanyl or the fentanyl patch is that you ensure your patient does not have more than one patch on at a time because overdose can occur. I heard about a patient who had EMS called, emergency medical services, or an ambulance called for oversedation and respiratory depression. Come to find out, upon examination of the patient, they had multiple fentanyl patches in place. The Narcan was given, the excess fentanyl patches are removed, and the patient did recover, but that's really scary to know that that can happen. So when your patient has a fentanyl patch in the clinical setting on your MAR, it will most likely and hopefully have a place for you to indicate that you have removed the old patch before applying the new one. So that's an important safety consideration to take into account so that you don't accidentally overdose your patient with transdermal fentanyl. So I hope this brief overview of 8 common pain medications helps you understand their use, safety considerations, things you're going to watch for in the clinical setting. And before we go, I want to offer you a freebie that I've created called the Pharmacology Success Pack. With this pack, you can get a head start on pharmacology, learning about drug names and naming conventions, learning about reversal agents such as the naloxone that I mentioned, common unit conversions that you're going to need to do your dosage calculations, and tips on safe medication administration. Just go to straightanursingstudent.com/pharmsuccess, and it'll take you to a link where you can grab that Pharmacology Success Pack. And I hope to see you back here next week. We're going to be talking about a maternal newborn topic of ectopic pregnancy. So I will see you back here for that. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
At a time when change is constant and we are pulled in far too many directions, we need a way to stay present to life and to increase our ability to remain calm, think clearly, and maintain our well-being. Many studies indicate mindfulness improves our mental, emotional, and physical health. On A Mindful Moment with Teresa McKee, you can learn how to practice mindfulness and enjoy its many benefits. Tune in for guided meditations and to hear tips and advice from some of the most respected experts in the fields of mental health and mindfulness. The world truly can be a better place. It all starts with a mindful moment.